Okay, so we have already finished with prostaglandins and leukotrienes. Now, very important topic to discuss is that prostaglandins analogues and all the drugs which lies in the category of prostaglandins. We will talk about them in this lecture. So the prostaglandins analogues are of two different types, which we can divide as a natural precursor or natural prostaglandins, or it can be a synthetic variant of prostaglandins. However, there is also one more, which is the semi-synthetic form, but we will keep it in a natural category, right? Because most of the thing of that drug is directly natural. So let's start with these drugs. So the first one is alprostadil. This is our PGE1 analog. Analogues means something that is acting directly as that particular group. So in this case, alprostadil is directly a type of E1 prostaglandin. The second one is dinoprostone. Dinoprostone. This is again E2 type of prostaglandin. The third one is dinoprost. Now it is important to remember that the one is dinoprostone and second one is dinoprost. The dinoprost is F2 alpha. Right. Then fourth one is the carboprost. The carboprost is also an F2 alpha agonist. Now earlier I said you that one of them is a semi-synthetic type. So the carboprost is actually a semi-synthetic. Okay, semi-synthetic prostaglandin. Right. Now let's talk about synthetic ones. Synthetic ones, again for the E1. So the first one is E1. It is misoprostol. This is again your E1 analog. Second is dinoprostone. Dinoprost is E2. Then there is latanoprost. Dinoprostone, travoprost and travoprost, and sixth one is tafoloprost. The main suffix over here is this prost, right? So the prefix is prost. So they will have this prost word everywhere. Prost. See, everywhere we can see this prost. So whenever we see a prost, it is a prostaglandin analog. Alright, in few books, the categorization is, I don't know whether it's given wrong or something else, but this is the actual classification, right? The book that we used to refer in our med school, it was saying that latanoprost is actually an E2 type of synthetic prostaglandin analog, but actually it is an F2 alpha. So all these four is F2 alpha. Right. There's also one more we can write over here is epoprostenol. Epoprostenol is again PGI2. Right. Now let's try to see how that actually works. So let's make a quick table. Okay, the drug, its potency, its duration of action, and its broad uses. Okay, we'll not talk so much about the epoprostenol because not so much used. Also we have many other drugs which causes the same function, so we tend to use them more than the prostaglandins, right? But anyway, let's see all of them. First one was uh, alprostadil, alprostadil, alprostadil. This one was E1 natural analog. Potency is not that much. Okay, the first thing to remember is that whenever we talk about natural and synthetic, one thing is that naturals are usually less potent and have shorter half-life. On the other hand, synthetic ones are more potent and has longer half-life. Okay, right, so the alprostadil has a potency because it's the natural precursor, not precursor, the natural compound, so it has a less potency, and its duration is short, usually in minutes. Again, in different people it may vary differently, and because of this it is used in erectile dysfunction. Again, we have other drugs, sildenafil, tadalafil, which we can use in the case of erectile dysfunction, but prostaglandins, yeah, we can also use that, but there are again better drugs for that thing. Then maintaining patent ductus arteriosus. Now first thing must come in your mind that it has a shortened duration. How it can be used as a PDA in an intrauterine life? For example, we need to maintain a PDA in the fetal stage. Okay, so we must use a compound which has a longer action, right? So we used to achieve this by the same drug by a continuous infusion. Okay, continuous infusion of alprostadil to maintain the PDA. Right. Why do we use some more powerful drugs when we don't need that particular action? Right. The second one, okay, so this one was E1 and it was natural. Second one is misoprostol. Misoprostol, this is also E1 and it is synthetic. Misoprostol is more potent than alprostadil and it is longer, right? And because of all this action, this is the best drug which we can use for medical termination of pregnancy. It can also be used for peptic ulcers, peptic ulcer protection or preventions, and it can be also used for labor induction. Now those guys who are familiar with obs and gynae must argue on this point that hey, we have this drug called as oxytocin, right? That also works the same. Then why are we using misoprostol for this? I will come on that point sooner. So the third one is dinoprostone. Dinoprost, or first let's do dinoprostone. So dinoprostone is again E2 and it is natural. Being natural, it is less potent when it lasts a little bit minute, 2 hours. Okay, and it is used for cervical ripening. So there are stages, right, for delivering a baby. First of all, there is cervical ripening, dilatation, followed by contraction of uterine muscles, which causes the expulsion of the baby. So cervical ripening, and also it can be used for labor induction. All the different types of drugs have different tendencies. Some may last longer, some has more potency, and so and so. So depending upon our usage, we choose one particular type of drug that is for our interest. Next is dinoprostone, right? Dinoprostone. So this is again one drug which is categorized as a natural drug in the book of K.D. Tripathi, 8th edition, but it is actually a synthetic variant. And because of this is again E2. This is more potent and it lasts longer, and this can be also used for MTP and cervical ripening. Now one thing is that all these drugs can be used as a pill, then they can be also used as a gel, which can be applied directly onto the cervix for its ripening. Now using like that, it causes less side effects, right? Next is dinoprostone intravaginally. Yeah. Anyway, dinoprost is F2 alpha. Was dinoprost F2 alpha? Dinoprost is F2 alpha, yeah. Right, so dinoprost, again, it is a natural, and because of this it has less potency. It is short acting, and in human body we don't use dinoprost so much. It is much of a veterinary uses, or for animals veterinary uses. Okay, for animals. In humans we don't use it so much. The next one is the carboprost. Carboprost is again same one, F2 alpha, and the carboprost is semi-synthetic, and because of this potency is a little bit more than the usual natural ones, and it is longer. It is again used for PPH, so any drug which actually contract the uterine muscles can be used for either MTP. It can be also used for PPH. Now in particular we use carboprost more than the dinoprost or the misoprostol. Why? Because it acts longer, right? So it gives a longer protection than for the PPH, and being more potent, it can be used for second trimester MTP, second trimester abortion. The seventh one is latanoprost. Let's do a rest of them all together because they are literally almost similar. The only thing they differ in is their side effects. So we check for hematoprost. So we check for their comorbidities, right? Before giving it to the patient. Travoprost and trafuloprost. All of them has because all of them are synthetic, right? Their actions are even long, and they are used for glaucoma patient. Remember we already discussed that the F2 alpha analogues actually help us for ocular inflammation, and it is used for glaucoma patient. So glaucoma, it is probably the one of the best drugs which is used for the glaucoma, right? So glaucoma, however, there are also some side effects. Now side effect need not necessarily to be bad. For example, the bimetoprost actually increases the eyelashes, but please don't use it for your cosmetical purposes, okay? There are again different other drugs which can do the same. Don't use them. Anyways, so increase eyelash length, it can cause irritation, redness, and few of them can also cause iris pigmentation, right? So this was particularly the classification and this important chart. Now how to choose for the MTP? So there are several uses, right? So let's check all the uses let's write all the uses at one place. So first one was MTP. So for MTP, we know that we can use those drugs which was acting on the uterus, right? This one, okay, PGE2, F2 alpha, and thromboxane A2. E2, F2 alpha, and thromboxane A2. Now the best part is that they all causes the contraction, right, of the smooth muscles of uterus, right? Now we can use all those drugs which is potent, which target. Oh, one more thing. Rather than E2, there's also this E1. Okay, E1. E1 is anti-inflammatory, E2 was pro-inflammatory. We already discussed it, I guess, over here. Yeah. So let's write one more over here. It is used for a smooth muscle contraction, or let's write better one, uterine contraction. That is, it act on smooth muscle, right? So we were over here. So all these prostaglandins actually have tendencies, okay, to cause the uterine contraction, right? Now, depending upon how much the duration it will act for, what is the potency, we can choose several of them, right? One combination that is most widely used is actually a combination of mifepristone and misoprostol. So for MTP, mifepristone, okay, it is again a progesterone type of drug, which we will not focus more over here. Plus we can use for misoprostol, right? So the misoprostol over here, we discussed that it was used for MTP, right? We can also use for E2. For example, in the case of dinoprostone, we can use for the same one. Then we can also use for carboprost, right? That is particularly for the MTP because the expulsion is so much powerful, right? Mifepristone and misoprostol, there is one particular dosage which is about 600 milligram, and for the misoprostol it's about 400 microgram, right? This combination is used for contraction, right? It actually induces the contraction. And the rest of these other drugs, mifepristone is actually used for the preparation for the expulsion by cervical ripening and cervical dilatation, right? And also it actually make the endometrium more in how can I show that, the habitat for the attachment of fertilized egg become inhostile, right? Right, so we know that now these two drugs is used for MTP, and this mifepristone actually is so the misoprostol was prostaglandin analog. The mifepristone is progesterone. Did I say it was a progesterone? Sorry, it was a progesterone blocker. And it actually causes the shedding of endometrium, right? And we actually give the progesterone in the before pregnancy. It actually makes the area less favorable for the attachment site, right? So we are done with the MTP of the pregnancy. The second one is for the inducing of labor. Now previously I told you that I will try to compare the oxytocin with the prostaglandins. So usually we use oxytocin, okay, at the time of delivering the baby, right? Because it is much more better. However, it is not, the oxytocin itself is not used for the MTP. Why? Because in the early pregnancy, the receptors for the prostaglandins, okay, let's say this is our uterus. Within the uterus, there will be active receptors for prostaglandins, okay, but early pregnancy, and there will be almost less to almost inactivated oxytocin receptors, okay. So we use, it is less, okay. So as the pregnancy goes on, this oxytocin receptor actually keep increasing in number. Oxytocin is actually much more potent than the prostaglandins actually for contraction. However, in early pregnancy, because the amount is less, we are more and more dependent of our prostaglandins to cause MTP. Right. So the next one is inducing labor. Yes, we can use oxytocin for that, because for the labor it means that the pregnancy is almost reached to the third trimester end, right? We can use oxytocin, but at the same time we can use the prostaglandin for causing the dilatation and the ripening of cervix. So yeah, cervix ripening plus dilatation. The third one is, okay, so we already said this thing, cervical ripening and dilatation. Next one is PPH. PPH, it decreases the PPH. Again, oxytocin is much more better if for the PPH, but we can also use the prostaglandins, particularly most potent one, for example the carboprost. Okay, so where were we? We were not using dinoprostone so much. Okay, we don't use dinoprostone so much because it is much more for animals. Right, so yeah, PPH is done. The next one is glaucoma. All the F2 alphas agonist we can use for. The next one is peptic ulcer healing. Peptic ulcer, okay, protection, prevention. The next one is maintaining PDA. Maintaining PDA. The next one is pulmonary hypertension. It decreases pulmonary hypertension because of the vasoconstriction properties. Few of them again have vasoconstrictive property and vasodilatation property, so depending upon our usage we can use that particular type of prostaglandin. And lastly is Raynaud's disease, that is our peripheral type of vascular disease. Right, so let's quickly discuss the different types of side effects which these prostaglandins analogues causes. So first one is again nausea, vomiting, watery diarrhea. It can cause uterine contraction. It can cause cramps, because whenever we give drugs which acts on the smooth muscles, it will not only act on the smooth muscles of uterine muscles, it will act on the smooth muscle all over the body, and whenever they will contract they can cause cramps. They can also cause angina. Okay, now it totally depends upon the dosage, how much the dose actually is. So the less dose, okay, one thing to remember is that one concept, the E1 was anti-inflammatory, the E2 was pro-inflammatory, and both of them were used for MTP. Both were causing muscle contraction. It means that E1 being anti-inflammatory has power to cause muscle contraction and thus have power to cause angina. Now this angina is actually dose dependent. Okay, let's set it over here. Now in higher dose, angina will be present, angina will be more on higher dose of E1. Less dose of E1 is anti-inflammatory. So the E1, let's see which drug actually has E1 and more potency. The misoprostol, whenever it is given for a longer period of time, because it has more and more higher potency, it can actually induce an angina in the patient. Right, so in a scenario where the MTP is not able to be achieved and the fetus is still there, it is not coming out, and we need to keep on giving the E1 again and again, there's a high chance that a patient can have angina or the cramps in the body. Right. The next one is vaginal bleeding, because of a few of them actually causes the vasodilatation, right? Which can again cause bleeding, shivering, fever, malaise is also caused by prostaglandins. So either prostaglandin natural or as a drugs, doesn't matter, in the body it can induce all these things. It can decrease the BP because of vasodilatation property. Earlier we know that drugs actually have less here. It was actually decreasing the BP more, okay, because the vasoconstrictive property was increasing the BP only by slightly more, okay, but the main drug was causing fall in the BP. Right. Then there is increased amount of heart rate because of the reflective actions. Alright, so this was all about the prostaglandins. Now, one very very important concept is for the gastric lining protection, and we must know this because the next topic of discussion will be the NSAIDs, and before moving on to the NSAID, we must know about this important feature, which is the gastric lining protection or protective action of these prostaglandins. So we know that there are about two drugs, two prostaglandins, right? Yeah, over here, the I2 and the E2. I2 and the E2, they both are causing vasodilation, right? So whenever in the stomach, so in stomach, okay, let's say this is our stomach, right? Usually, not usually, we have the HCl in our stomach, right? So whenever there is less, let's say there's less amount of less, not less, but there is a vasoconstrictive action, right? So because of the vasoconstrictive action, there will be less amount of bicarbonates reaching the stomach to neutralize this HCl, right? And because of this, huge amount of HCl will be secreted, and there will be less lining of protective film over the stomach, right? Over the stomach for the protection. Now, we have this two important one, which are the E2 and I2, right? They both were causing dilation, right? And also, yes, we have also one more E1 which we can use, but naturally whenever this thing is produced, it causes the vasodilation action, okay? Both of them actually causes the vasodilation, which again causes huge amount of bicarbonate to reach the gastric lining, okay? Again, it causes the huge amount of, and overall the thickness of bicarb film increases, and it causes the protection of gastric mucosa, right? Now the thing is that the I2 is more of a, where it is, yeah, so the I2 was causing more vasodilation than the E2, right? Which means that where were we? So yeah, I2 was causing more vasodilation than the E2, right? So it says it must be like I2 is more gastroprotective, we can say. Yes and no, both, because I2 only increases the diameter of the blood vessels, right? However, for the protection, it does not necessarily we need the vasodilation. Also the mucus production, okay, the mucus production by the goblet cells. This is the mucus production, the goblet cells, right? This is also as much as important than the bicarbs, right? So for the protection, right, we need two things: bicarb, that it was coming from vasodilation, and the mucus, right? Now the best part is that E2 also has the vasodilation property, as well as it stimulate the goblet cells to increase mucus production. Now this mucus production in the stomach, it is helpful. However, in the case of inflammation at the time of let's say some respiratory system is involved, or some infection over there in that system, in the respiratory system, whenever there is huge amount of mucus production, it actually causes the blockage. I'll tell you one more research topic that you can work on, right? So overall, this E2 is more gastroprotective than I2, right? Let's say there is huge amount of HCl production because of, let's say, Zollinger-Ellison syndrome, and there's overall vasodilation. Now, just having vasodilation doesn't mean it will be helpful. Yes, it will secrete more and more bicarb, but also it will be at a higher risk for damage, and it can cause gastric bleeding as well, right? So there has to be this leverage, right? A seesaw mechanism of HCl and bicarb production. If there is more bicarb and less HCl production, it will be helpful for us. However, HCl is also necessary for digestion of the food. So overall, vitamin C and different vitamin B12 and so on are deficient in these kind of patient who have less amount of HCl. So have an appropriate amount of HCl, have an appropriate amount of bicarb as well, to have a nice balance, right? Now in the condition where HCl is increased, right, Zollinger-Ellison syndrome, okay, and bicarb is still the same, it will have a power to destroy these vasodilated blood vessels, right? And because of this, there will be more and more higher chance of gastric bleeding. Alright, so this was one concept. So not just don't only have huge amount of bicarb, also sideways have this mucus secretions in the lining, right? Then there are also some other drugs which is actually protecting that particular ulcers. Anyways, yeah, so overall E2 has huge amount of mucus production in the lining of stomach, providing an additional barrier. So overall E2 is the E1 is pro-inflammatory, and it is the E2 is pro-inflammatory, right? And but it is still protective in the case of stomach. In the other area, it is again disastrous for us, right? So yes, during inflammation, E2 in lungs particularly, it increases the production of mucus, which is causing more and more obstruction. So from here we can just say a research topic, maybe in future there will be, I don't know, that if E2 in lungs can increase mucus production, which can cause obstruction, and this obstruction can be disastrous, right? Disastrous if the patient have some earlier disease, right? Let's say a history of either asthma or COPD, let's say. So the patient, whenever E2 activity will be more, there will be more amount of mucus production, there will be more amount of obstruction, which can cause even more and more severe asthma and COPD, right? So this PGE2, right, the E2 was in particular, where were we? So E2 in lungs. E2 in lungs was causing bronchodilation. However, it was also decreasing the amount of histamine, right? So E2 was having two properties. It was bronchodilation it was causing decrease histamine production. However, it was increasing mucus production, right? All these things are okay. We can use some other drugs to decrease or to cause the bronchodilation, to decrease the histamine. However, this is a very nice mucoproductive prostaglandin, right? Now these things are actually attained by some particular receptors. So for the E2, there are two types of receptors: the EP2 and the EP4 type of receptor. Now the EP and EP4 actually mean the E prostaglandin receptors type 2 and type 4. There are about 1 to 4 type of receptors, right? EP1, EP2, EP3 and EP4. So however, PGE2, right, it can also cause bronchoconstriction, but just right now we just said it was causing bronchodilation. Yes, it depends upon which this E2 actually works upon, right? So this action, okay, the E2, whenever it acts on EP2 and EP4, it actually increases this bronchodilation property. However, there is no control whether this E2 will work on other receptor as well. So E2 actually can work on 4 different receptors: the EP1, EP type 2, EP type 3 and EP type 4. Whenever this E2 will work on whenever it will work on EP1, it will cause bronchoconstriction, and it can cause severe asthma. It can even cause to severe COPD conditions. EP2 is better for us because it was causing bronchodilation and vasodilation. EP3 is almost similar to EP1 in causing bronchoconstriction. Also side-wise, it was increasing inflammation, right? And for the fourth one is similar to the second one in causing bronchodilation and vasodilation. So the field of interest is that we can, in the case, let's say the patient has COPD, asthma, depending upon how many receptors are there, which type of receptors are there. For example, the patient have huge expression of EP1 receptors in the lungs. That person with asthma will have more amount of bronchoconstriction, and vice versa. For the EP2, they will cause bronchodilation. So in some patient they can sustain asthma very well. In some patient there is even more amount of, in more severe condition of asthma and COPD. So these are the receptors actually which plays a vital role. So in research process, we can use some, let's say, some antibodies, right, to directly block this EP1 and EP3, right? Or we can actually some drugs maybe which can cause upregulation in the expression of these two receptors, EP2 and EP4, right? So I don't know whether these drugs are already being synthesized or not, but yeah, as of now we can use this pathways, some drugs, some ways by which we can block EP1 and EP3. However, there's also this thing, right, which some people might have question like, okay, why to just block EP1 and EP3? We have better ways to decrease this bronchoconstriction by using steroids, right? Yes, very nice answer, but there's also condition where asthmatic which are actually steroid resistant. So steroid resistant asthmatics, so for them, let's say antibodies against EP1 in particular, then maybe EP3, but at least EP1. Okay, it will be helpful in at least this particular type of patients, right? So this is again a research topic, you don't need to remember. uh, it is a research topic which you can use. You can do the paper review and so. So yeah, this was all about the prostaglandins, analogues, how they act, their ways of MTPs, all these uses, side effects. Very, very important. This part of stomach, how I2 and E2 actually causes the protection. In particular, the E2 is more and more better than the I2. So for gastric lining protection, the E2 is much more better than the I2 because E2 was causing these two things: vasodilation as well as mucus production. Right. So the next topic we will discuss about the drugs which was causing the blockage of these two enzymes, COX-1 and COX-2. Again, there are about several drugs. Some are particularly COX-2 receptor blocker, the COX-2 enzyme blockers. Some are like non-specific type of drugs. They blocks both COX-1 and COX-2. We will discuss more of those drugs in details because that drug is literally very, very important. Most commonly used drugs, right? And also I'll tell you in different areas how they, some doctors, not all of them, just to decrease the pain of the patient, they actually play with the patient's condition. Right. So that was all about prostaglandins. Okay, next topic, NSAIDs, and I'll try to quickly discuss about the corticosteroid as well. So yeah, that's all.